My name is Seth Pollack. I'm the director of the Sarcoma program at the Lurie Cancer Center, which is the cancer center in Chicago that's affiliated with Northwestern University. And I'm also the Stephen Rosen Professor of Cancer Biology, which means that, in addition to my clinical work with sarcoma patients, I also have a lab where we try and understand the immunobiology of different cancers and come up with new therapies. Epithelioid sarcomas are a type of soft tissue sarcoma. Sarcomas are about 1% of all cancers. And I always tell people they're rare, but they're not that rare. If you go asking around, you may even find somebody that knows somebody with a soft tissue sarcoma. But what's also really true is that there's a lot of different types of sarcoma. So, I see different people count them up different ways, depending on how detailed you want to be in terms of grouping them. But people say there's over 50, over 75. I've even heard people say there's over 100. Some of them really are. Some of them are not that rare, and some of them really are rare. And I would say epithelioid sarcoma is one of the more rare ones. It's probably 1 to 2% of the soft tissue sarcoma. So if there's about 13,000 total soft tissue sarcomas in the US every year, there's probably in the order of like 1 to 200 epithelioid sarcomas. They tend to affect younger people. So the mean age, at least in one study, was 44. And they do seem to increase a little bit in older people too, but they can also affect young people. So there are even some children that get epithelioid sarcoma. It's a little bit more prevalent in men compared with women. And in fact, the women that get it may even do a little bit better clinically. In terms of, sometimes people ask me if there's a difference in sort of the racial distribution, but I see that pretty much is reflective of the population where we're treating. A lot of the times people will classify epithelioid sarcoma as having two main types, and they'll call them the proximal type or the distal type. And actually the way these types are classified is really the way it looks to the pathologist under the microscope. So sometimes, when we say proximal, usually in medicine, that means like close in, like close to the trunk, and distal means like way out, like in the extremities. So the classic presentation of distal epithelioid sarcoma would be like in the hand or the kind of like arms or legs, whereas the proximal is really more in the trunk, and particularly in the pelvis. That's a really tough place for epithelioid sarcoma to go. Now, I mentioned that really the way we classify them is based on the pathology. So there are cases where it's a really strange thing. You could say that you have a proximal epithelioid sarcoma, even though it's anatomically distal, right? Even though it's in the hand, because the pathologist thinks it looks more like the classic proximal epithelioid sarcoma. It's really, really important to have your pathology reviewed at a major center by an experienced bone and soft tissue pathologist, and all the major centers have them. We know that when pathologists that are not experienced with sarcoma review sarcoma cases, they frequently misclassify them. And this is especially important with epithelioid sarcoma. And one thing that can happen with epithelioid sarcoma is some pathologists will mistake it for what's called a reactive process, meaning a bunch of inflammation that's happening in the area because there are cells that are sometimes called benign granulomas, or they're like a confluence of cells that, and it looks like a reactive process. And if you're having tumors, if things don't make sense to you, sometimes I'll hear about patients, they'll have a tumor, it's growing, they had a biopsy, their doctor says, oh, don't worry about it, and they don't worry about it, but then a month or two goes by and that tumor is still growing and it's causing them symptoms. Don't take no for an answer. I mean, you should go and get yourself an evaluation at a place where they're experienced in dealing with sarcomas, because an experienced bone and soft tissue pathologist will know how to look at this and say, yes, this is really reactive, or no, this is a type of cancer. You mentioned about gene testing. So there is a specific feature of these epithelioid sarcomas. It's called INI1 loss. So these tumors can lose expression of INI1. They don't need to, but they frequently do. And if your tumor has lost INI1, that is like seals the deal. That's the icing on the cake. Case closed, you have epithelioid sarcoma. If your tumor has these, if it's in the ballpark, if it has these general features and it's lost INI1, that will be case closed, epithelioid sarcoma. But you could still have epithelioid sarcoma and not have INI1 loss. So, and you really need a very experienced pathologist, a bone and soft tissue sarcoma pathologist, a specialist pathologist, to without INI1 loss, to say that's epithelioid sarcoma, right? Because most of these tumors will lose INI1. You don't need fancy gene testing to detect INI1 loss. In fact, at our center, if something's looking like epithelioid sarcoma, they'll do sort of like a conventional test. It's called immunohistochemistry, and they can look for INI1 loss. But the good thing is that more and more people are just getting gene testing as a matter of course, as a matter of routine, and it really is affecting diagnosis. And these tests can see INI1 loss, and I think it will help us find more patients with epithelioid sarcoma. Yeah, epithelioid sarcoma is a really tough cancer. It's a really tough cancer. And a lot of the times, patients present with incurable disease. In fact, maybe 25% of the time. And in not quite half, but almost half, they present with advanced stage localized disease. So unlike other sarcomas, which almost never go to the lymph nodes, epithelioid sarcoma can go to the lymph nodes, and frequently does. And that can be a big problem. And a lot of the times it will present just with localized disease. And we think of that as being curable, but it's always, when I see an epithelioid sarcoma patient, I'm always thinking that patient is a high risk patient, even if they have all of the best features. If it's a lower grade epithelioid sarcoma, if it's a small epithelioid sarcoma, those are good features. And in any other sarcoma type, not any other sarcoma type, but in most other sarcoma types, I might not worry about that patient that much. With epithelioid sarcoma, I always have my guard up. I always think of those patients as being patients we have to watch really, really closely. Because really the 10-year survival, and I kind of think of that as being sort of like the cure rate, it's really like 50%. Those are sort of the numbers that we have for this cancer. Surgery, if you have locally resectable disease, surgery is a good idea. There are a variety of different philosophies for how to handle the lymph nodes in epithelioid sarcoma patients, but I think that's, and I'm not sure there's a right way or a wrong way, but I think you want to make sure that your team is very conscious of that they're thinking it through. Radiation is an important part of the treatments of these cancers in a localized setting. And then chemotherapy. So I'm a medical oncologist. I'm the one that gives chemotherapy. I tend to think of myself as being pretty conservative. I don't give a lot of patients, sarcoma patients, chemotherapy in the curative setting, but epithelioid sarcoma is one where I tend to be more aggressive because, as I said, These are really high-risk patients, and I tend to just really, if they're in the curative setting, I want to throw the kitchen sink at them, because as I said, it's really 50-50 in terms of the long-term outcomes for these patients. So that's the curative setting. You mentioned Tazverik, tazemetostat. That is the new drug that we have for epithelioid sarcoma. It's an entirely new class of drugs. It's called an EZH2 inhibitor. It's the molecular pathway that it targets. That is not yet, it doesn't have a role yet in the setting of patients with where their disease is localized and we are going for a cure. I mean, not in the typical patient anyways. So if you have a patient, if I have a patient with a tumor and it's sort of conventional situation, maybe they're getting chemo, radiation, and then surgery, maybe we probably wouldn't use this drug, tazemetostat. There might be some patients where it's kind of a borderline case, we're still kind of thinking cure, but it's a tough case. I've seen some atypical situations where we have tried to move it into a different situation, but the typical patient that we're treating with this new drug, tazemetostat, is in the metastatic setting. So when I say the metastatic setting, what I mean is that the cancer's spread. And when the cancer has spread, usually we sort of change our mindset a little bit. So when the cancer is localized, my philosophy is like, okay, we have to be as aggressive as possible. We're gonna, do whatever it takes, even if it means the patient's going to have to suffer in the short term. We're gonna get them through this, and they're gonna hopefully live a long life afterwards, right? But in the metastatic setting, that's usually we think maybe we're not going to be able to cure this patient, and then we have to balance the, helping them live for a long time, but also maintaining their quality of life, right? So that they're able to do all the things they want to do and be present for it and be able to enjoy them, and not just have their, physical body there, but be preoccupied with throwing up and dealing with pain and all these other things that cancer patients have to deal with. So there's a number of different treatments we use for epithelioid sarcoma. Standard chemotherapy, doxorubicin, is probably the most commonly used one, and most people will use it in the upfront setting for epithelioid sarcoma. I'm pretty aggressive about using tazemetostat as early as possible. There's a clinical trial right now that I'm not sure if it's enrolling today, but it will be soon if it's not today, combining doxorubicin and tazemetostat. But right now, the way because it's not quite open here yet anyways, the way we're doing things is we're treating patients with doxorubicin first in general, and then treating them with tazemetostat second. I really, really like tazemetostat. It is one of my favorite new drugs, and the reason why is because it's very well tolerated. Patients take it and they don't get sick. They can get a little bit of fatigue. They can get a little bit of nausea, but we can usually control that with nausea medications, right? Maybe they lose their appetite a little bit, they can get constipated, but as far as cancer drugs go, it's really, really easy to do. It doesn't always work, but the thing is that when it works, a lot of the times it can work for a really long time. So we have a lot of patients, I've had patients on it for years. If you can have a drug that will control a patient's disease for a really long time, and I've had patients with really bad disease on it. If you can control a patient's disease for years with excellent quality of life, that's what it's all about, for a patient with incurable disease. So I'm a big fan of it. Some other things that we'll do, there's a drug called pazopanib that's an FDA-approved drug for soft tissue sarcomas, and epithelioid sarcoma falls into that category. So that's something that we'll do. And I have had some patients do well with pazopanib, and it is generally, I don't think it's as well tolerated as tazemetostat, but compared to some of the hard-hitting chemos we'll sometimes use, I think it does a good job. And then for refractory patients, I am using off-label PD-1 inhibitors, and I have had responses in epithelioid sarcoma. So, and I think we were gonna, talking about kind of emerging options. I have heard people trying to look more carefully to try and define a role for these PD-1 inhibitors, and even trying to combine them with drugs like tazemetostat. So that's my approach to treating these patients with epithelioid sarcoma. The immunotherapies, I think they're really exciting. I love PD-1 inhibitors like tazemetostat. I think they're very well tolerated. So I always feel like it's worth a shot, especially for a patient that's been through some different treatments and has progressed. There is a lot happening in terms of, we talked about pazopanib, and there's other drugs in that class that I think might do just as well or better than pazopanib in the future. There are also, I think we're learning a lot about how the tumors use energy. It's called like the metabolism of the tumors, and ways to sort of target that so that the tumor can't get energy as it should. So I think there's a lot happening. There's also a lot happening in terms of some of the other treatment modalities. For example, we've been able to use protons for some patients that had recurrent epithelioid sarcoma or epithelioid sarcoma in very difficult locations. So even in radiation, I think things are getting better all the time. One thing I'll just say is it can be very frustrating for epithelioid sarcoma patients that don't have a doctor in their life that has ever treated an epithelioid sarcoma patient. And if that's you, or if that's the person that you know and love with epithelioid sarcoma, I would say it can't hurt to get another opinion from a major sarcoma center, and you don't have to go to them for all of your visits. Usually, I have people all the time from who come from a few hours away, so they wouldn't want to come to me for treatment all the time, but they just come and we chat like once a year or every 6 months, and I got their doctor on my cell phone, and we text, and we just try and kind of stay in the loop. So I think it's important that people have somebody experienced with epithelioid sarcoma involved in their care, and I think they can do that without replacing their whole team.